Okay, so I'm just going to get started with my little intro so you guys can get to your presentation and we can fit in as much good info as we can. But hello to everybody online, in person with me, and all of the rooms that you're attending. And thanks for coming to Provincial Pharmacy Rounds today. So our session today for the month of October, we've readjusted a couple things. We're going to do some infectious disease and antimicrobial stewardship learning. And because it was a hit last year, we're bringing back the same format where we grabbed all of our ID and AMS specialists across the province, and we're just going to grill them with questions after they give us a quick presentation on some of the most common topics in their area of practice lately. We won't grill them too hard, but I think there's a formal presentation for the first little bit of this. So please keep yourselves muted for the time being and save your questions to that question and answer period near the end. I'll try to keep an eye on the chat if you don't have a mic and wanted to put your question there and help to try to moderate the situation. And yeah, we'll make do as we go. Other admin stuff, the meeting is recorded. That little red button is on, and the recording will be posted to Thinkific after the presentation. So give me a week or so, maybe two. I'll get it online soon. So you can watch that or refer to it later. What else? I think that's mostly it. I'll post a evaluation so we can get your ideas for future rounds topics near the end of the presentation. And I think that's all I got, so I'll hand it off to our ID crew.
Great. Thanks, Alina. You can still hear me okay? Thumbs up. Okay, I'm going to assume yes. So we are thrilled to be here with all of you guys for our second annual Ask Us Anything session. So as Alina said, we are going to answer your questions that you submitted ahead of time and hopefully have a bit of a live Q&A as well. And it's presented to you by the micromanagers. So this is our self-appointed name that the three of us have given ourselves. We feel it's pretty clever, very fitting. So feel free to refer to us as such in the future. So who are we exactly? I'm Kristin, one of the antimicrobial stewardship pharmacists here in Regina. I have the fantastic Mel Kucey beside me here, and then the wonderful Danielle Shmyr in Saskatoon. So before we answer your questions, vision, mission, values, and philosophy of care of the SHA. So by gathering in this way today, admitting what we don't know, asking questions, having discussion, sharing information, all with the goal of improving care, I think this pretty perfectly encompasses all of the values of the SHA. I acknowledge that we are gathering on treaties 2, 4, 5, 6, and possibly some people on 8 and 10 territories of the Cree, Dene, Assiniboine, Nakota, and Saulteaux, and the homeland of the Dakota, Lakota, and Métis. A land acknowledgement is an opportunity to recognize the traditional caretakers of this land. For me, it's also an opportunity to reflect on the very painful history of colonization in this country, in this province, and how that persists today and has led to these stark differences in health outcomes between Indigenous and non-Indigenous people. And if we connect that to the content of this presentation, we see that very obviously when it comes to prevalence of infections and outcomes of treatment of infections. So I just encourage you all to take this opportunity or a moment today to reflect on this painful history and the consequences of it, as well as your role as a healthcare provider in truth and reconciliation, because words are only words. And change happens with changed beliefs and behaviors and actions. So objectives of our presentation today to answer your questions. So we got a few questions on pleural space infections. So Mel's going to start us off and talk about those. Then Danielle will take over and talk about clinical situations where transition from IV to oral antibiotics is safe and effective, probably for many disease states that we've considered, traditionally these IV-only disease states. Then I'm going to do a bit of a rapid fire answer to some of the questions, and then we hope to have an opportunity for a live Q&A. So please be brave, ask your questions so that everybody can benefit from that discussion. So I will hand it over to Mel.
Okay, do you know how we can get rid of that on the screen?
It's just on a dual monitor.
Lovely. Okay, thank you. Okay, so I'm going to talk about pleural space infections. We got a couple questions. How do I know when antibiotics are indicated? How long do I treat for? So I'm going to go over all of that. Please bear with me because I'm not feeling the greatest today, and I'm hoping I get through this without a coughing fit. I was joking to Kristin earlier that I feel like I'm developing my own pleural effusion. I'm not, but hopefully not. Anyways, okay, so we're going to go over that. All right, where's my...
Your mouse went away.
Oh, here it is. Okay. So before we kind of dive into everything, I do want to go over some terminology because some of these words and terms are used interchangeably and they don't all mean the same things, and we actually treat them a little bit differently. So it is important to make that differentiation. So a pleural effusion, this is simply just accumulation of fluid within the pleural space. And a pleural effusion can be transudative, and this is more of a passive flow of fluid. So it's usually due to some sort of change in hydrostatic or oncotic pressure. So for example, if you have a patient who's fluid overload and congestive heart failure, you get a buildup of fluid within the blood vessels. This increases the hydrostatic pressure and forces fluid out of the blood vessels into surrounding tissue into the pleural space. An exudative pleural effusion, in these cases, there's some sort of underlying inflammation that's occurring that is causing the blood vessels to be a little bit more leaky, allowing for things like proteins and cells then leave the blood vessels and enter surrounding tissues and into the pleural space. An exudative pleural effusion can be due to infectious causes or non-infectious causes like an underlying malignancy, for example. Now, a parapneumonic pleural effusion, this is a pleural effusion that arises in association with a pneumonia. So we know that there's a known infection there. Now, this can be uncomplicated. So if it's uncomplicated, this is a sterile exudative fluid due to inflammation. So there's infection present, but the bacteria haven't made its way into the pleural fluid yet. And so there's no bacteria and no pus. This can then progress into a complicated parapneumonic pleural effusion. And at this point, this is where we now have bacterial invasion into the pleural space, but still no frank pus. This can then further evolve into an empyema, where we now have a collection of pus in the pleural space, and this is now an abscess within the pleural cavity. So building onto that, sources of empyema or causes of empyema, if you will, the most common cause of an empyema is where you have an underlying pneumonia and then you get translocation of microorganisms from the lung into the pleural space. There are other less common causes of empyema. So you can get empyema from a hematogenous spread from an underlying bacteremia. You can also get direct inoculation of a microorganism into the pleural space, either from surgery or some sort of trauma. You can get translocation of microorganisms from a contiguous source of infection, etc. So when we talk about the diagnostic evaluation, most pleural effusions are picked up on a chest X-ray for a patient who is being worked up for an underlying pneumonia. And when you detect or see a pleural effusion on a chest X-ray, usually these patients will undergo further diagnostic imaging, either through an ultrasound or CT, to get a better look at that effusion, look at the size of that effusion, determine if drainage is needed and the feasibility of that drainage. And then an ultrasound or a CT can then be used to help guide that drainage. Now, when we decide to drain that pleural effusion through thoracentesis, the fluid analysis and the investigations that we send off for are important, because then they help us characterize that pleural effusion and help us identify the etiology or the cause of that pleural effusion. So physicians will often send for things like gram stain and culture, cell counts and differential. This is to help determine if there's an underlying bacterial infection. They'll send off for things like cytology to rule out things like malignancy. They'll send for protein and LDH, and this is to help us differentiate or determine if this is a transudative or an exudative effusion. And they can send for other things like glucose and proteins. And these are more surrogate markers of underlying bacterial infection. They should also be sending the blood for total protein and LDH, because that can also help us determine if this is transudative or exudative. Now, when we are trying to determine if this is a transudative effusion or an exudative effusion, one of the tools that we can use is called the Lights criteria on the right-hand side of the slide there. So the Lights criteria looks at things like protein and LDH. And if this is a transudative pleural effusion, remember this is passive flow of fluid into the pleural space. So we wouldn't expect to see high amounts of protein. We wouldn't expect to see high amounts of LDH. Those would all be relatively low. On the other hand, if this was an exudative pleural effusion, there's some sort of underlying inflammation going on, causing the blood vessels to be leaky, allowing for proteins and cells to transfer into the pleural space. So we would expect to see higher amounts of protein, higher amounts of LDH, because likely there's some sort of tissue damage that's occurring. So if the patient meets any one of those criteria, then they are considered to have an exudative pleural effusion. Now, if it's an exudative pleural effusion, remember I said an exudative pleural effusion can have infectious causes and it can have non-infectious causes. So that's why we send off for other investigations like gram staining, culture, cell counts differential, glucose and protein to help us determine, is this a bacterial cause or maybe a non-infectious cause? Okay, so we're going to talk about the different stages of a peripneumonic effusion because they are thought to happen kind of in a sequential developmental phase. So remember a peripneumonic effusion, this is an effusion that happens adjacent to an underlying pneumonia. So stage 0 would be we have a pneumonia present, we have a confirmed infection. Now, in some cases, not all, but in some cases, pneumonias can progress to a peripneumonic effusion. And so the first stage, stage 1, would be an uncomplicated peripneumonic effusion. So at this point, there's no bacteria present. It's still an exudative effusion. So you may or may not have elevated white blood cells. You will have an elevated LDH, but it's not going to be overly high. And you're going to have normal pH and glucose because there's no bacteria present at this point. So the treatment here, we need to use antibiotics because we know there's infection present. And they may or may not require drainage. It'll depend on the size of the effusion and how symptomatic the patient is. Now, this can further progress to stage 2 and become a more complicated peripneumonic effusion. And so at this point, we now have bacteria present. Bacteria have made its way into this pleural effusion. So once again, this is an exudative effusion. We have bacteria present, so we would expect to see more white blood cells. We would expect to see higher amounts of LDH. We would see lower pH, potentially lower glucose because there's bacteria present and they're eating up the surrounding glucose. Treatment in this case, obviously we need antibiotics because we've got infection and we definitely want drainage because we don't want it to progress to an empyema. So drainage is really important here. Now, stage 3, this is where it has progressed and has become an empyema. And so we now have got full-blown pus that is now draining from the pleural space. That's the easiest one to obviously diagnose because you pop the drain in and then it's just purulent material that pours out. So you know you've got yourself an empyema. Bacteria may or may not be present. It'll depend on if the patient's had antibiotics or not. And so the treatment in this case is antibiotics plus drainage with or without surgery. Now, there are different types of surgery that you can do. You can do the full-on open thoracotomy where you're cutting into the chest wall, kind of decorticating the lungs, cleaning everything out. We don't do that often because it's a very extensive surgery and the recovery process is not great, as you can imagine. But there is another type of surgery that patients can be offered. It's called VATS, or a video-assisted thoracic surgery. We can do it here in Regina, but I don't often see that we do it. And I'm not really sure why that is. That's just our clinical practice. I think Saskatoon does it a little bit more often. It's less invasive than the open thoracotomy. And truthfully, we probably should be doing it more because source control is always much better than antibiotics, but we just don't see it that often here in Regina. Now, if we get to the point of empyema and the patient is not a surgical candidate, as you can imagine, it's frank pus that's draining, so it's a thicker fluid, right? And those aren't always easy to drain. You get a lot more fibrin buildup at this stage, and so fibrin can form these septations, and then you often get these like loculations. and it's a lot harder to drain this fluid. And so often what we'll do is we'll administer fibrinolytics intrapleurally, so things like alteplase or Dornase, to help break up those fibrin deposits and allow the pus and the fluid to flow a little bit easier to help with that drainage. And the alteplase, the Dornase, these are going to be a lot more effective at stage 2. Once we progress to stage 3, these things just become a lot more difficult to treat. So when we think about the microbiology, common causes of pneumonic pleural effusions are going to be from things like strep pneumo, strep anginosus, Staph aureus, anaerobes, strep pyogenes, some gram negatives. But when you think about the bacteria that might be causing this effusion, it's really going to depend on that clinical presentation and the initial pneumonia that you're dealing with. So for example, if your pneumonic effusion developed from a community-acquired pneumonia, you would expect to see more of a strep pneumo or maybe even a Staph aureus, especially if this was a post-viral presentation. If this effusion developed in association with an aspiration pneumonia, you might expect to see more strep anginosus, maybe even some anaerobes. This tends to be more polymicrobial. If it's a hospital-acquired pneumonia, you might expect to see more gram negatives. Getting a tickle. 1 second. Okay. Now, when we talk about antibiotic therapy, empiric therapy, if this is a community-acquired pneumonia that's evolved into a pleural effusion, ceftriaxone, metronidazole are obviously reasonable empiric options. The choice to cover anaerobes is a bit controversial. Your guidelines and other references are going to tell you probably need to add on anaerobic coverage. But when you speak to a couple of experts, some of them say you probably don't need it. But in general, it's probably going to depend on the clinical presentation, the organism that you isolate, and the type of effusion. So for example, if you grow out something like a strep pneumo or a Staph aureus, these tend to be more monomicrobial. You're less likely to need to cover anaerobes in those scenarios. If you culture something like a strep anginosus and there was an underlying aspiration pneumonia, these tend to be more polymicrobial. So anaerobic coverage probably makes a little more sense in that case. If you have a patient who has more of a chronic empyema, and this has been going on for many months, anaerobic coverage makes sense in those cases. So it really depends on the clinical presentation. If this is a hospital-acquired infection that's developed into a pleural effusion, tazocin obviously is a good empiric choice here, plus or minus vanco. If there's an underlying pneumonia contributing to a pleural effusion, if they've had a recent MRSA swab and it's negative, you don't need vanco. And then we can obviously tailor our antibiotics based on culture and susceptibility results, but also, once again, just keeping in mind whether or not you think this is going to be monomicrobial or polymicrobial. And then once we've seen clinical improvement, we've had adequate drainage, you can transition to oral therapy. You don't need to finish the course on IV. So typically what this looks like is the patient is clinically improved, their symptoms have improved, they've defervesced, white blood cells have come down, the drains are out, no further drainage is required. At that point, you can look at transitioning to oral therapy to finish off the course. Almost done. When we talk about duration of therapy, so we're going to individualize duration of therapy based on the type of effusion that we're dealing with, how effective our drainage is or source control is, and based on the clinical and radiographic response of that patient. So we do repeat imaging in these scenarios because we need to assess or monitor the patient's response to therapy, and we need to see that this effusion is getting smaller, obviously, but we're not looking for complete radiographic resolution. Remember, radiographic resolution is going to like clinical resolution, which likes microbiological cure, okay? So we're not expecting the chest imaging to look completely back to normal or go back to normal, look like their baseline. We're expecting to see definitely improvements and no concerns for or no need for further drainage or source control, but we're not looking for complete radiographic resolution. So the duration of therapy for an uncomplicated pneumonic effusion usually is anywhere from 1 to 2 weeks. For a complicated, we're looking at 2 to 3 weeks. And then for an empyema, This is an abscess in the pleural space. So this is usually a 4 to 6 week course of therapy. Okay, so to wrap this up, in patients with the pleural effusion on chest imaging, the pleural fluid analysis, when you do that thoracentesis, that's essential because it helps us identify the etiology and the cause of that pleural effusion. In a peripneumonic effusion, this is an effusion that happens adjacent to a pneumonia. Antibiotics are needed with or without drainage, depending on the type of the effusion and the size of the effusion and how symptomatic the patient is. We adjust our empiric antibiotics based on culture and susceptibilities, keeping in mind if we think this is a monomicrobial or a more polymicrobial infection. We can transition to oral therapy once we've had clinical improvement and we've had adequate drainage and no further source control is needed. We do repeat imaging to monitor response to therapy, but we're not looking for complete radiographic resolution because that's going to lag clinical improvement. And once again, the duration is going to depend on the type of effusion that we're dealing with and the response to treatment. So I got through all of that without having a coughing fit. If you guys have any questions, should we get them to ask now or save it to
No,
the end?
we'll save it because I think we're going to run out of time. So we'll pass it over to Danielle.
All right, thanks guys. Can you guys hear me? Let me just give a quick thumbs up if you can. We're good? Awesome. Okay. Okay, so for the next 10 to 15 minutes, I'm going to answer some questions that came in about IV to PO concepts. So there were two kind of main themes that came out of the Ask Us Anything questions. The first was, can you summarize if it is possible to step down from IV to PO in cases of bone and joint infections? And then the second theme that came out was when to use or when can you use oral options like Septra, clindamycin, doxycycline for MRSA infections. So I will kind of start off really broad, answer some general sort of concepts about IV to PO, and then kind of get into some more specifics. So if you guys go to the next slide for me, please. Awesome. Okay, so the first concept we're going to talk about here, and this is just really nitpicky. There's a bit of a movement or a shift, so to speak, in the ID and stewardship world, and that is around the language when we talk about IV to PO. So step down implies that inferiority of oral in comparison to IV, and the evidence really suggests otherwise. So I urge you to use switch or transition instead. And then the second concept, sorry, you guys just moved into a different view. I don't know if, I mean, we can keep going like this. It's fine. It's just, it's not in presenter view anymore, but okay, that's fine. The second concept, sorry, technical difficulties here. The second concept is that microorganisms don't know, nor do they care how an antimicrobial gets there. The important point is that an antimicrobial does get to that site of infection at a high enough concentration and covers the organism that you're looking for, okay? And then the third concept, next slide, is that not only are antibiotics in general not benign, we all know that, that's a whole other presentation, but IV antibiotics also are not benign, especially when you compare them to oral antibiotics. So humans, are not meant to have plastic thrown into veins. And so when we throw plastic into veins, there are harms that are associated with that. So line infections, DVTs, thrombophlebitis, bleeding, fractured lines, and so on. And that can significantly impact care, prolong stay, and lead to other, adverse outcomes. So when, we can use oral, we want to use oral. Next slide, please. So the overarching answer here when considering IV to PO concepts is that in most cases, excluding sort of a couple sort of notable scenarios, which we'll talk about in the at the end, in most cases, oral therapy is appropriate if they meet, the following criteria. And we all know this, we've, seen this list before, but we're just going to go through it again. So the first is that the patient is clinically stable, right? So obviously they're off pressors, they are no longer, requiring All right, febrile, they're no longer, they're just clinically improving. They're able to tolerate oral, they're able to absorb oral, they don't have any sort of GI condition like diarrhea, vomiting that's preventing that oral absorption. The second point here, and this is important because sometimes we don't often think of this as pharmacists because source control is not, but point is that source control is achieved, right? So if they needed to go for surgery, they've gone for surgery. If they needed a drain, they've had a drain placed and it's adequately draining and the drain is ready to come out. If they need incision and drainage, all those sorts of things have happened, okay? So source control has been achieved. Again, that's not our job to do that as pharmacists, but we can ask the question. If you're ever wondering, okay, has source control been obtained? Ask the question. The fourth, I talked about absorbing oral. The fourth is that there's no psychosocial factors to prefer IV. So, you know, if you're going to discharge a patient on a long period of oral antibiotics, are they able to afford that medication? Are they able to house that medication? Are they able to properly store it? All those sorts of things. And are they going to be reliable at taking that medication? And so thinking about some of those social factors with your patients. And then the fifth, and this becomes really important when we start to talk about some of those like IV only, like traditional IV only indications, is that there's a published regimen that covers that target bacteria at that target site. All right, next. If you want to advance there. So I'm just going to take a moment. I threw Brad Spellberg's face up here because I'm channeling him right now, and majority of this content comes from his website. So if this is a very high level overview, but I urge you to go and look at his website. He has basically summarized all the information associated with showing that oral is as good as IV. So if you want any more detail, feel free to check out his website. It's excellent. Okay, so now let's get into bone and joint. So there's the specific question asking about when can you use oral in bone and joint infections? So when you look back at the data on osteomyelitis and both prosthetic joint and native joint septic arthritis, it's really old data that established the practice that bone and joint infections requires IV therapy. This comes from a trial done in 1970 that was, you know, really quite poorly designed to today's standards. It was retrospective, observational in nature. It had a wide range of population. It looked at acute osteomyelitis, chronic osteomyelitis. It had children, it had adults, it used aminoglycosides, you know, so it really wasn't up to today's standards in terms of evidence. But what they concluded from this trial was that for bone and joint infections, a combination of surgical debridement, that still stands, and prolonged therapy, 4 to 6 weeks of parenteral antibiotics is required. If you want to advance, perfect, thank you. So now if you look, fast forward to today, there's tons of data showing that oral therapy is as good as IV for bone and joint infections. So we have both pharmacokinetic data that confirms certain oral antibiotics reach adequate levels in the bone. So there's lots of data to suggest that clindamycin, fluoroquinolones, linezolid, and Septra achieve adequate levels in the bone when taken orally. This outweighs our beta-lactams. So there isn't a ton of pharmacokinetic or clinical outcome data for beta-lactams. When given orally, they may not reach adequate levels in the bone. So we use beta-lactams a little bit, but preferentially we will use the ones highlighted in green there. And then there's also clinical trial outcome data showing that oral has similar outcomes to IV. So we're not going to go through all of that, but I threw the OVIVA trial up here on the screen. The OVIVA trial was done in 2019. It's our largest randomized control trial looking at bone and joint infections and oral therapy. So it was over 1,000 patients, which is a lot for an ID trial. And patients were randomized to 6 weeks of oral in comparison to IV. And the outcome here was that oral was non-inferior to IV at 1 year. You can see the organisms there on the slide. So Staph aureus was fairly well represented. We've got strep, some cons, and then gram-negative bacilli in that was seen as well. Next slide, please. Several years later, a systematic review was completed in 2023 or published in 2023, and that included 8 randomized control trials looking at IV versus PO for osteomyelitis and bone and joint. And again, it showed no statistical difference between clinical cure between oral and IV. Next slide. Earlier this year, the Association of Medical Microbiology and Infectious Diseases Canada, so that's AMI, and the Canadian Orthopedic Association issued a joint statement on this very topic. So they answered the question, okay, do we endorse using oral antibiotics, and should we be using oral antibiotics in bone and joint infections, including prosthetic joint? So you can search that document and see what it says. But in summary, they conclude that yes, you can use highly bioavailable oral antibiotics for bone and joint, including prosthetic joint infections, in collaboration with ID if criteria is met. Next slide, please. So they list their criteria in a bit of a different fashion than I have here, but basically is what we've gone through already. So number one, that patient is clinically stable. So if they, you're seeing clinical improvement, they're afebrile, their CRP is coming down. Number two, any sort of source control has been achieved. So if they needed a washout, revision, gone back for a revision, an IND, that has been completed. The third is that they can absorb oral. We all know that as pharmacists. The fourth, again, is that psychosocial factors to prefer IV. So often we're discharging patients, or if we're going to throw them on oral, we're discharging them for, 4 to 6, maybe even 8 weeks of oral antibiotics. Are they able to, do that? Are they able to afford it? Do they have a place to house that medication? And then fifth, which I've added in here now, this is, if you compare it to my previous criteria, I have added in involve infectious diseases here for bone and joint. So this isn't, there are some other places that might be a little bit ahead of us because this isn't necessarily like new practice changing evidence. It is practice changing, but it's not that new. If you look at the Oviva trial, it was published in 2019, but here it hasn't necessarily been the standard of care in Saskatchewan to use oral antibiotics for bone and joint infection. So recently our Saskatoon ID group got together with the Saskatoon Ortho group to discuss this very topic and decided that yes, it is appropriate. We should be using more oral antibiotics in our bone and joint infections, but because of the lower comfort level, we would like to see ID involved in these cases. So if you have patients who you think might be appropriate to transition to oral, I would suggest involving in ID in those cases. And then number 6, I talked about this already, again, because this is historically a traditional IV only disease state, that there's a published regimen that covers that target bacteria at that target site. So now you're thinking, okay, well, if I'm going to suggest this, where do I find this regimen? Well, I believe it was last year, there were the wiki guidelines that were published. If you just want to advance to the next slide, I will throw up. So the wiki guidelines are a group of infectious disease practitioners that have basically developed a new set of guidelines alongside sort of your traditional IDSA guidelines. And they seek to answer, look at the evidence to determine whether they can answer certain questions about clinical care. And the question here for bone and joint and osteomyelitis was, can we use oral therapy? And they also had concluded that yes, we can, as long as there's a published regimen. And so within these guidelines, there is a table that shows the antibiotics, the dose, and sort of the regimen that has published evidence for bone and joint infections. So again, it's kind of those ones that we talked about earlier that have that good pharmacokinetic data as well as clinical outcome data. So your fluoroquinolones, Septra, clindamycin is on this list, linezolid, amoxiclav specifically for diabetic feet, and then doxycycline. There is not as much evidence, but anecdotally people do use it, and so it is included, not in this chart, but it is included within those guidelines as well. Next slide, please. So that was the first question, was can you summarize if it is possible? And yes, obviously I've gone through that. It is certainly possible. Historically, though, it has not been the standard of care and there are lower comfort levels with it. So we suggest involving ID in these situations until there's sort of greater comfort with this practice here in Saskatchewan. Okay, what about other infections? So intra-abdominal infections, can you use oral therapy? Yes, the same principles. If you go through that list, the same principles apply. We want to ensure, especially with intra-abdominal infections, that, if there's something that's needed to be drained, it has been drained, and so on. CNS infections, meningitis, no, I don't think you're going to find any evidence to suggest using oral antibiotics for, a strep pneumomeningitis. So I would say no, we would not use oral therapy there. But brain abscesses, yes, and sort of those same principles apply. So as long as you have a highly bioavailable antibiotic that's going to penetrate the CNS, yes, you can use oral. So we often use metronidazole, oral metronidazole 500 TID in brain abscesses when anaerobic coverage is required, which is most of the case with a brain abscess. Fluoroquinolones and linezolid also have excellent bioavailability and penetrate the CNS. Bacteremia, yes, we can and should be using oral therapy once patients meet that criteria. There is an exception, and I'll talk about that on the next slide. And then endocarditis kind of falls into the same category as osteomyelitis. It sort of has this historical, dogma that we have to use IV, and more evidence is suggesting that that's probably not the case and we can use oral. I would say not too many people are pushing the boundaries on that a ton yet. Maybe the odd ID physician here and there in Saskatoon and Regina when you're kind of between a rock and a hard place. So not really. We'll talk about that on the next slide if you just want to advance there. Thank you. Okay, so the notable exceptions here. So for bacteremia, the one exception is that we do not, it is not considered the standard of care to transition to oral for Staph aureus bacteremia. So there is the Sabato trial that came out just last year, I believe, or in 2023, and that looked at essentially low risk patients and whether we can transition them to oral. And they did find that oral was non-inferior to IV for those sorts of patients. I wouldn't say that the trouble with Staph aureus bacteremia, as we all know, is that we sometimes have a hard time identifying which patients are low risk and whether there's other metastatic foci of infection. There's another trial that's going to be coming out in the next couple of years, the SNAP trial. That's a very well-designed trial, and that's going to help to provide further guidance. So I suspect most will probably wait until that trial is out to see what that trial says in terms of oral therapy. So for now, the standard of care here remains IV therapy unless you're between a rock and a hard place. And if you are between a rock and a hard place, consult ID. And the endocarditis, similar situation. I kind of talked about this already. Similar to osteomyelitis, historical data has really set that precedent that IV is greater than PO when it may not necessarily be. There have been 3 randomized control trials that have shown that the efficacy is similar between IV and PO. But again, really the standard of therapy remains IV just because the stakes are quite high. And if you're ever between a rock and a hard place and you're considering oral, that's an automatic ID consult there. Next slide. Awesome. So the last question there was, when to use oral options like Septra, Clinda, Doxy for MRSA infections. I hope I've, for the most part, answered this already. Really, you're going to avoid these for those exceptions. So Staph aureus bacteremia, endocarditis, that's not going to be your go-to therapy using oral therapy because you're going to probably be using IV. Other MRSA infections, those are obviously all on the table. And there is less evidence, as I alluded to, for doxycycline and osteomyelitis and bone and joint, but anecdotally, physicians have seen success with it. So you might see it, and that concludes my session, or section, I should say. I will hand it back over to Kristin.
Do you want to disconnect yours? I have a new laptop and it is stretching my patience like nothing else. So sorry for our technological challenges. All right, so I'm going to rapid fire answer a few of the remaining questions. First one was, when do we add empiric acyclovir in cases of suspected meningitis? So I'm going to provide an oversimplified answer. If anybody needs clarification, feel free to reach out. So CNS infections can be caused by all kinds of microbes, bacteria being the most common, but also viruses, fungi, and various other things. So when we're adding acyclovir in cases of suspected CNS infections, we're really covering 2 of the main viruses likely to cause these infections, one being HSV, that's going to be the most likely, and VZV. Other viruses can cause CNS infections, but they're less likely. So how do we know then when we should add it and when not? So this is kind of based on the clinical presentation and if we suspect the presence of just strictly meningitis or encephalitis as well, okay? So acute bacterial meningitis is going to present or should ideally present in this kind of classic picture that we're familiar with: fever, neck stiffness, photophobia. Okay, so viral CNS infections, though, are more likely to be encephalitis or meningoencephalitis. So the best way I know how to differentiate the two between encephalitis and meningitis is the presence or absence of normal brain function. Okay, so in meningitis, people should maintain normal brain function. We should not have an altered mental status, no seizures, nothing like that. Where with encephalitis, you might get this altered mental status. Picture seizures, focal, neurological signs on imaging. This is more in keeping with encephalitis. So if this is suspected, then it's reasonable to add on acyclovir. It's not always so black and white. These things can kind of overlap, but if there's any suspicion for encephalitis, which us as pharmacists, we can be communicating with prescribers to see if that's the case, then this is when we would add on acyclovir. And then in those who are severely immunocompromised and present with any possible CNS infection, we're probably adding it at that point. Another thing pharmacists can support with is ensuring that we're ordering the correct tests when lumbar punctures are done. So when an LP is done, we need to send that for cell counts. Okay, that for the first important reason is that it helps us to determine the presence of infection at all. And then the cell counts as well can help us to differentiate between a bacterial and viral etiology. Then an LP should also be sent for bacterial culture. And then as far as testing for viruses, we must do PCR. So we do not do viral cultures, although this is commonly misordered. So viral PCRs, so ensuring that that LP is sent for HSV PCR and possibly VZV. Okay, so there is my very simple answer to that question. Advance, please. Next one was an update on antibiogram creation across the province. So there's been a lot of work on this in the past couple of years, and I'm happy to say that for 2025, so those antibiograms will come out early next year, we should have one created for every single microlab in the province. Okay, so every area, geographical location should have an antibiogram. The best place to find that information, of course, is on First Line. But if you prefer this kind of classic grid-looking depiction of the antibiogram, you can find those on the library website, and that's where that QR code will take you. At this point, what you'll find on First Line and on the library is an antibiogram for nearly every microlab in the province. We're almost there, but next year should be the year. Next question was, what is the pharmacist's role in syphilis treatment? So I would argue that we should have a big role. We have epidemic rates of syphilis in this province, so every healthcare provider should have a basic understanding and be involved in this care. So because of this, we have created, or not we, I guess, Courtney Dalton was really the one to create this, a guideline on First Line that will give you guidance on all of these things. So information on screening, because we as pharmacists should be suggesting screening for syphilis in those with risk factors if it's not done, assisting with interpretation of lab results and staging of syphilis. This is not an easy thing to do. So that First Line guideline has a tool on there to help with that. If you need support in that, of course, you can reach out to one of us, but this also brings us to the next point, liaising with public health. So all cases of syphilis in the province are followed by public health. So they're really the source of truth for all of this stuff. They know if patients were previously treated, regardless of if they were inpatient or outpatient. They'll know how they were staged. They can help with interpretation of serology, all those kinds of things. So make friends with public health. And then, of course, we can be involved in recommending appropriate treatment depending on the stage. But the really big thing here is reassessment of penicillin allergies. Penicillin is first-line treatment for any stage of syphilis. That's what we want to be giving. So I think pharmacists have a big role to play in ensuring that pen allergies are true and helping to decide which therapy is safest. Next thing is just a quick highlight that there have been many recent guideline updates or creation for UTIs. I'm not going to go through any detail here. If any of you are going to the CSHP Sask branch educational sessions, Danielle is going to talk more about this, but just for you to be aware, the IDSA has released a guideline this year on complicated UTIs. in which they've kind of reclassified uncomplicated versus complicated. They give a lot of direction on durations of therapy for complicated UTIs, which, spoilers, is basically 7 days for all types of complicated UTI. And then a notable difference here in classification is that not all people with male physiology are automatically considered complicated. As well, there's a new-ish wiki guideline, and then our first line guidelines as well, which use these two things as a reference for our Saskatchewan guidelines. So check those out. Be stewards with the antibiotics for UTI. Okay, so that was rapid fire. What time is it? We have 11 minutes, but we're also happy to stay a bit late, I'm sure. I'm going to stop sharing my screen if I can figure out how to do that here. All right, so I have not looked at the chat at all. I don't know if any questions have come in there, but please, we just need someone to be brave and ask the first one, and then usually things get rolling. So if you have questions, you can unmute yourself. You can put them in the chat. I know you have questions. I'm looking at you, Yorkton. Where are you?
Are you able to hear me?
Sort of. It's quiet, but yes.
Maybe I will talk louder. For the oral transition for like osteomyelitis with the question with Septra, doxycycline, etc., do you need to make sure that those are actually on the culture and sensitivity, or can you change it over empirically?
I can take this because I did this section. I would say that like it probably depends on the clinical situation. I would say that just because it's culture negative doesn't mean that you can't switch to oral, because really if you're doing IV antibiotics and empirically covering something, then you could also use oral antibiotics and empirically cover something. So as long as you're looking at what's most likely to be the causative pathogen and then covering that and using one of the agents listed, then that is fine.
Sorry, I meant more so like say you're treating Staph aureus and we don't have it on the culture and sensitivity that it's sensitive to like clindamycin. Can we empirically
I
like,
see what
look
you're
at
saying.
antibiogram? Yeah.
You know what? We just call the micro lab because they run the culture and sensitivities on all Staph aureus isolates against all those oral antibiotics. So we always have behind the scenes, we have fluoroquinolone susceptibility, Clinda susceptibility, linezolid susceptibility, Septra, doxy. So those if you've isolated Staph aureus, you have the susceptibility.
Awesome. Thank you.
I'll read out a question in the chat. Not sure if you can see them again. From BUH, we see a lot of spinal epidural abscess from IVDU. Is there any evidence on using PO here? So spinal epidural abscess.
Danielle, do you want to take that one again?
Yeah, I mean, I would say like our physicians are starting to do it. Do I know like I'd have to go back and look at those trials to see how many of them, like if they had vertebral osteo, how many of them also had spinal epidural abscesses. I would say the same principles apply as long as you've had drainage or whatever surgical source control, then yes. But again, it would be with ID.
Yeah, it's a similar practice here. We routinely do not use oral antibiotics for epidural abscess or vertebral osteo. There might be a rare case, and always it's ID's call if that's done or not. I see we have another question in the chat. Any comments on the clinical utility of BAL for directing antifungal treatment? This is a loaded question. Let's see if Mel wants to try that one.
Okay, so first I'll start off by saying, I mean, I don't know the clinical circumstances or the indication that physicians use to do a BAL. But when I will start off by saying that one, Candida pneumonia is, I'm not gonna say it's not a thing, but it's just like, it's exceedingly rare. So often when you have a patient, and usually this is a critically ill patient, but when we have a patient who's maybe not doing well in the ICU and we throw on like fluconazole or caspofungin and they've got an underlying pneumonia, It's not necessarily because we're truly worried about a candida pneumonia, because that is exceedingly rare. It's more maybe because we're suspecting like a disseminated candidiasis. So I'll say that. Now, if we do a BAL, it's more likely that we're going to see other things other than Candida. Like fungal pneumonia, one just isn't rare. But if we are to see some sort of like fungi causing an underlying pneumonia, it would be things like an aspergillus, for example. Yeah, so I think I'll leave it at that. And I mean, fluconazole and caspofungin are not great. We wouldn't be using to treat an aspergillus. We'd be looking at something like an amphotericin or voriconazole, for example. So anything to add?
No, I think that's great. I hope that answers the question.
I like to say that Candida pneumonia is a fictitious diagnosis.
Yes, we're actually going to we're not going to report it from sputum samples here in Regina anymore. That was a bit of a stewardship intervention. It's not implemented yet, but it's coming. Okay, more questions in the chat. Paige, fluoroquinolones, moderate dose Septra and Clindol have higher rates of complications in C. diff than ceftriaxone. Have we used these enough in practice yet to see if there will be an increase in secondary complications from multiple weeks of oral therapy? Danielle, I'm not remembering these trials off the top of my head if they looked at those outcomes in the PO switch.
Yeah, I'd have to go double check on that. Mel and I actually were just having this conversation, I think about a week ago or 2 weeks ago. And I agree. I mean, you think about putting someone on like a fluoroquinolone for 6 weeks. Obviously we know fluoroquinolones have a lot of adverse effects associated with them. It is kind of a sort of a scary thought, but again, you think about the complications associated with having a line in. I'd have to go back and look at those trials specifically, but I think as long as you're monitoring, patients are being monitored, again, that's one of the social factors to allowing them to be on oral for a long-term treatment course as an outpatient. As long as those patients are able to be monitored for these adverse effects, I would say that, you know, complications of an IV line versus an oral antibiotic, you know.
And you're always treating like that individual patient. So I mean, if you have a patient who has a lot of risk factors for C. diff, maybe they've had a history of C. diff in the past, they're an elderly person, maybe they're a cancer patient, like all these risk factors are adding up, you're probably very unlikely to put this person on oral Clinda and send them home for 4 weeks. So I mean, you're always looking at individual patient characteristics too.
Yeah, that's always part of the discussion we have with the ID docs when they're considering this. So it's definitely not for everyone. You have to consider the risks even with PO. Next question for the PO switch to epidural abscess, is there a specific amount of time that you want patients on IV therapy after source control before switching? I mean, I can just take a stab and Danielle, you can add. There's no minimum amount of time. This is really based on one source control. So this has to be like totally adequate. So there's no plan to go in and do more source control. Like all of the source control is complete, and then they have to be clinically doing quite well. So this could be, I don't know, 1-2 weeks, maybe more, but there's no like set duration that they need to be on oral antibiotics. We really have to have the source control, clinical improvement, and kind of, you know, be ready to go home type of thing. Anything to add, Danielle?
No, I agree. And I just like to say that goes like across the board for like all disease states. There's no magical number that tells you that it's okay to switch from IV to oral. It all depends on meeting that criteria and the patient in front of you.
Okay, next question was already asked to you this week, so I'll maybe let you take it so that I don't risk contradicting what you say. So do we need to always use pseudomonal dosing for Cipro, so the 750 BID for urinary tract infection caused by Pseudomonas?
So interestingly enough, you can ask about 10 ID practitioners the same question and they will all answer it differently. So if we do answer this differently, I think that's okay. But I said no for a urinary tract infection, especially for an uncomplicated urinary tract infection. I would suggest that you likely do not need pseudomonal dosing of a fluoroquinolone because it concentrates well in the urine at high enough concentration. So I would suggest not using. If you had a complicated urinary tract infection, maybe like a pyelonephritis, or if you had like a renal abscess and it was associated with Pseudomonas, then I would use anti-Pseudomonal dosing. And then without getting too nitty gritty into like MICs and the PK data, that's a whole other presentation on its own. But the simple answer is for uncomplicated UTIs, I wouldn't.
And I think that would probably be the only scenario where I wouldn't consider using the 750 BID for a pseudomonal dose. I know Dr. Manion, Jessie Manion, she's one of our fantastic microbiologists here. She's definitely ingrained in my head, when you have Pseudomonas and you think it's an actual pathogen and not just a colonization, if you're going to treat it, hit it hard, because it's very easy to flip that to resistant. So, so for every other infection, if you're going to treat a Pseudomonas because you think it's actually causing infection, hit it hard with the appropriate dose.
Yeah, I would agree that for a very uncomplicated cystitis, we probably don't need the higher dose. But everything else, if we can do it, we should. All right, I don't see any more questions in the chat, and we are at 1 o'clock. So I will thank you all so much for your participation and for listening. And I assume, I don't know if Alina has a closing message, but I'll let her talk if she does.
My closing message is thank you guys so much for your expertise. Definitely want to just hang out with you, not only because you're great people, but also because so I can pick your brains about everything ID. So yes, thank you again so much for presenting and putting together such great answers for these common questions. I will also throw out, I put into the chat just the link to our provincial rounds evaluation survey. It'll be active for the rest of the day, I believe. So that P rounds 2, 3, 4, follow that, and give us some ideas for future presentations. Tell us how you like this one, and we'll forward the feedback on to our presenters. Yeah, if you guys want to send me the slides, I'll get it posted with the recording in the next couple weeks here. And thanks again for doing such a great job.
Thank you,
Thank you.
everybody.